welcome Professor Singh's presentation. Please, Dave.
Thank you, and good morning, good evening, everyone. I'd like to start by thanking Dr. Chu, Dr. Prayer, Dr. Junior Tu for putting together this webinar. It's a real honor and a privilege for me to be here today. And I'm going to talk a little bit about craniofacial sleep medicine, thinking outside the box. So I'm going to look at some concepts from a review point of view and think how we can use our current information and knowledge to go to the next steps in this. As mentioned by Dr. Chu, I'm the founder of a company called Rima Sleep Inc. and also the founder of the company called Vivo Therapeutics. I'm no longer associated with that company, but I am the inventor of the mRNA appliance, the DNA appliance, the mmRNA appliance, and the DNA appliance for children. All of those devices have been FDA cleared for mild, moderate, and severe sleep apnea in adults and also in children. So last year was a wonderful year for me. I became a fellow of the Pierre Fauchard Academy. And today I'm very honored to be speaking for the International Craniofacial Chang-Gung webinar. And today I'm going to review the philosophy of mandibular advancement device therapy in general terms. We're going to look at the functional morphology of the upper airway. How does the upper airway behave? All right, so this is the title of the talk, Craniofacial Sleep Medicine, Thinking Outside the Box. And then I already mentioned my disclosures to you already. And then we'll talk a little bit about today's teaching objectives, review mandibular advancement device therapy, examine functional morphology of the upper airway. We'll talk a little bit about the electrostimulatory techniques for upper airway maintenance. We have a good a number of surgeons on this talk as well. We'll review the control of upper airway homeostasis, and then taking all that into account, we'll look at maybe some new ideas in terms of upper airway management. So that is the objectives for today. So we'll start with the idea of mandibular advancement devices. I know we have several orthodontists and dentists and dental sleep medicine experts here today. And so I'm going to ask our medical colleagues, what is the function of a mandibular advancement device? And according to our medical colleagues, the use of these devices is to mechanically enlarge the airway. So that idea is historical. For first aid, we used to, pull the jaw forwards, get the tongue out of the airway. It's still used in anesthesia, of course, but it's a historical idea that we mechanically enlarge the airway. So I want to look at that in a bit more detail. And the question is, how do we treat mild or moderate sleep apnea, OSA, using any mandibular advancement device that you prefer? And the idea is that it increases the caliber, the size of the airway, and it reduces its collapsibility, which is a very nice principle. In real life, of course, we know it's not so simple because in some cases, when you use a mandibular advancement device in a responder, you get a very nice response. The airway opens, it widens, and it's a good response. However, in other cases, you have non-responders. You can pull the mandible as far forwards as you like, and there will be no change in the upper airway morphology. And so one of the kind of ideas is to understand why would people be responders and non-responders to this type of therapy. So when to decide clinically if a patient is going to be suitable for a mandibular advancement device, we can use DICE, which is drug-induced sleep endoscopy. And most of the surgeons in the audience are already familiar with that. But for those who are not familiar with it, it is performed either in an operating room or maybe in a clinic. If it's performed in a dental clinic, for example, we need to make sure that the basic resuscitation equipment is available, such as oxygen supply, ambu bag, that kind of thing. And then we have the anesthesiologist doing the sedation, and the level of sedation is pretty critical. The bispectral index should be between about 70 and 50. and the median targeted control infusion should be around 3.2 micrograms per milliliter. So the idea is to say, okay, we're going to sedate these patients and to mimic sleep. And then what we're going to do is pull the mandible forwards and then using the endoscope to say, hey, how does the upper airway respond? So we can look at the level of the soft palate at the velum level. And what we can see is in some cases, the first panel A, that the airway opens in a anterior posterior plane. And in B, what happens, it opens in a medial lateral plane. And in C, it opens in a concentric, in a circular type of manner. So we can see that the behavior of the airway can vary in these different directions. If we go a little bit further down into the oropharynx, again, we can see this medial lateral opening. A bit further down the base of the tongue, we see this lateral opening also. And then looking at the tongue base, we have concentric opening down here. And then going further down towards the epiglottis, we've got anterior posterior opening, and we also have medial lateral opening. And so we see this difference of response, difference of behavior at different levels of the upper airway. And we can use information to empirically decide whether this patient would be suitable or not for a mandibular advancement device. Now, how do we explain the changes of that airway morphology? How do we explain it from a principal point of view? So the differences in cross-sectional area can be explained by using the muscles that contribute to the pharyngeal walls. And specifically for the lateral wall, the stylopharyngeus muscle acts in a lateral manner. And you can see the red arrows here. And this is why you get the medial-lateral opening, because this lateral wall, stylopharyngeus, is pulling on this and making it into an oval shape. However, in patients who have got sleep apnea, the genioglossus does most of the work. And the genioglossus is a tongue muscle. You pull the tongue forwards, you see the yellow arrow here, and now you have this anterior posterior opening. And so what we can see here is that there seems to be at least two, maybe three or four different patterns of opening of the airway depending on the muscle function. And I would say this, and again, it's a hypothesis, is that tongue protrusion is a compensatory mechanism in OSA. In other words, the airway has collapsed because of the pharyngeal walls. And to compensate for that, the tongue is protruded to open the airway in this anterior posterior plane. So we need to pay a little more attention to the lateral walls. And so the idea I mentioned here is that the tongue is being compensating the same way that if you have nasal obstruction, you compensate by doing mouth breathing. The default setting for humans is nasal breathing. But if the nasal cavity, the nasal airway is compromised, obstructed, or blocked, then you go to mouth breathing. So similarly in OSA, you're using this anterior posterior genioglossus as a compensatory mechanism. But if we look at the lateral walls, we've got both the stylopharyngeus muscle, we also have the salpingopharyngeus muscle, and both of these are involved in lateral pharyngeal airway, the wall collapse during sleep apnea. So what is the role of these longitudinal muscles, the stylopharyngeus and the salpingopharyngeus muscle, in a lateral wall collapse? Well, here's a very nice study that came out recently, and these surgeons are looking at the outcomes and success following multi-level surgery in both positional and non-positional obstructive sleep apnea. And what they found is for both the non-positional and the positional groups, both groups showed improvement following upper airway surgery. But the interesting finding for me was that about 70%, actually 69% of the patients belonging to the non-positional group converted to the positional group after the surgery. There's a very interesting finding. It's a very big number that you've changed the behavior of the airway. And the question we have to ask is, what is the mechanism to explain the change in lateral wall behavior pre-surgically and post-surgically? And with that understanding, can we use that to develop some further techniques maybe in the future? So I was looking at this paper and I actually wrote to the editor to saying, how do we explain this mechanism? And so what we know is that the relationship between the upstream pressure, the critical collapsing pressure of the airway, the downstream pressure determines whether the airway is restricted, partially obstructed, or completely closed. And so we need to look at the pressure kind of gradient between the upstream pressure, let's say in the nose, and then the critical collapsing pressure, which is in the pharynx, and the downstream pressure, which is right down in the pulmonary alveoli. And depending on that pressure gradient, we can say whether the airway will be constricted, whether it's partially collapsed, or whether you have complete sleep apnea. And so we want to look at the mechanisms of how this lateral wall is behaving to say this will be the clinical outcome. Now, to look at the lateral wall behavior, what I suggested in this response is that the upper airway is viscoelastic, and what it shows is hysteresis post-surgically. In other words, that the airway has physiological properties of elasticity, but it shows hysteresis after the surgery. And the reason for that is because of increased fibrosis, maybe of the pharyngeal fascia. And this is what changes the transition from non-positional sleep apnea to positional apnea by stabilizing the lateral pharyngeal walls. So this is the kind of idea that we're exploring to say, how do we take airway behavior into consideration, bearing in mind the structure and the properties of the upper airway? And the property I'm looking at is two things: viscoelasticity and hysteresis. Now, we all know hysteresis, but just to remind ourselves, it's a characteristic of viscoelastic materials where the loading and the unloading do not follow the same curve. So here we have a graph showing a stress-strain relationship, and you know this is Hooke's law. So then the extension is proportional to the load applied, a nice straight line. And when you remove the load, the recovery is proportional to the load taken off. It's a nice straight line. This is an elastic system. This is not viscoelastic. This is an elastic system. Now let's take a tissue that we're familiar with. Let's take the periodontium, the so-called periodontal ligament. Now, again, this is a historical misnomer. It's not a ligament. It doesn't behave like a ligament. And what the periodontium actually behaves like is with this viscoelasticity. So when you put pressure on a tooth, if you were to bite on a hard piece of food like a carrot or an apple, the tooth will sink into the socket, and that is called initial elastic intrusion, which is following the curve that you can see, the stress strain curve on the left side of my screen. But if you keep on biting on the carrot, the tooth will keep on sinking into the socket, but at a slower pace. Now, when you stop biting on the carrot, the tooth will immediately recover initial elastic recovery, and then eventually, slowly, it will come back into occlusion over a small period of time. So we know that this viscoelasticity already exists in certain craniofacial tissues. And the question is, how does that apply to the upper airway? So here's hysteresis. So what I'm going to do here is we're going to load the tissue, and then we unload the tissue. You can see there's a difference in strain energy between loading and unloading. The line is not symmetric, and in between those two curves is the energy difference between loading and unloading. And this is the example of hysteresis, and this is the viscoelastic system that we're going to think about. So the key point here is that there's some energy considerations. When this airway is changing its shape, there's some energy considerations to bear in mind. Okay, so we're now thinking about the muscles of sleep apnea. Let's rethink about this muscle behavior during sleep apnea. And we need to understand why stylopharyngeus, why salpingopharyngeus are not working properly. And if we understand that, how to fix it to address the problems of sleep apnea. Okay, now the original idea was, hey, how do mandibular advancement devices work? Well, MADs are designed to widen the oropharynx and the velopharynx during sleep by stimulating stretch receptors. So this tissue of the airway is not a inanimate material. It's got biological behavior and it's got stretch receptors. And the way we do this, we want to minimize, the reason we do this is to minimize the airway collapse and enhance the openness of the upper airway. So easier said than done. Okay, I want to stimulate my receptors. I know I want to achieve, but again, I want to understand what is the mechanism, both physiologic and clinically, to achieve that. So let's look at upper airway collapse. This is a paper we did several years ago, 2007, and to look at upper airway collapse. And we used finite element analysis to look at upper airway behavior. And we use color coding, so it's easier to identify it. But before we do that, let's look at just review the upper airway, which you already know, but the Starling resistor, an elastic fluid-filled collapsible tube mounted inside a chamber filled with air. So in the top panel, we have normal unobstructed breathing and upper airway. And you can see that the pressure gradient upstream in the nose is much higher than the pressure in the downstream, downstream kind of in the lower airway, in the pulmonary alveoli, in the lung. And so this pressure gradient allows the airflow to go from the nasal airway all the way down to the pulmonary alveoli in the lungs, no problem. And in fact, we have been really focusing, generally speaking, on the upper airway behavior by saying, okay, we will do a nasal procedure to open the nasal airway. We'll do a maxillary procedure to widen the palatal structures. We'll do a mandibular procedure to pull the mandible forwards. All of this is to make sure that the upstream gradient allows this airflow to go through the airway right down to the pulmonary alveoli. That's kind of been one of the focuses. Now, when we think about snoring, upper airway resistance, UARS, and hypopnea, what we have is upper airway collapse because of reduced flow. And generally speaking, we look for about a 50% reduction in airflow limitation to say, hey, this is hypopnea. And when the hypopnea occurs, as you already know, there's desaturation, maybe 3% or 4% to say we can now score for a hypopnea. So in this case, the upper upstream pressure is greater than the critical collapsing pressure, which is still greater than the downstream pressure. And so you're getting flow, it's partial flow, a kind of restricted flow in that collapsible segment. And then we go a little further down and look at actual obstruction and occlusion of the upper airway. And here, the critical pressure, collapsing pressure, is greater than the upstream pressure, which is greater than the downstream pressure. And we have occlusion, collapse of the upper airway. So now we have to say, okay, we looked at the upper airway manipulation with nasal surgery, with palatal expansion, with mandibular advancement. What about this collapsible segment? Can we somehow manipulate that to prevent upper airway collapse? So let's look at upper airway collapse here. To prevent upper airway collapse, what can we do? You could be a physician, you could be an orthodontist, you could be a dentist. In this example here, we used a dental technique. It's called sibilant phoneme registration, the so-called phonetic bite. In other words, you ask the patient to count 61, 62, 63, 64 to make the S sound. And when you make the S sound during speech, your tongue comes up, sits on the palate, and opens the airway. So we're going to use that biological positioning, the physiological or functional position to say, hey, can I keep my airway open? So then we're going to measure the airway. We used a acoustic pharyngometer to do this study, and we looked at the functional residual capacity when you breathe out, the end tidal volume, and then when you breathe out completely, the residual volume. So we have the end of breathing and then the residual volume, and we compare the airway volumes to see if anything changed. And then when we did that, when you breathe out completely, you do find a 25% reduction in the upper airway volume when you compare it with just normal end tidal volume. And that's to be expected. When you breathe out, the airway gets smaller, and it's increased the risk because the airflow is being reduced, increased risk of collapse. Now, if you put these patients into the phonetic bite position and do the same measurement, when the residual volume is measured with and without the phonetic bite, with the phonetic bite, there's an increase in the airway volume by about 18%. So again, we are comparing the baseline functional residual capacity, normal end breath, normal breathing without any appliance. And then we superimpose the collapse at the residual volume. And you can see the blue area, the airway volume decreases by about 25%. Now we do the same thing. We're going to compare the collapse of the residual volume without any appliance with the phonetic bite in place. And what we find is the upper airway volume increased by about 15 to 18%. Now remember, the appliance of the phonetic bite was in the mouth, and there's very few changes actually in the mouth, but the changes that you see are in the upper airway, which is further down. So when people say you are mechanically enlarging the airway using a device, I'm not sure if that is the mechanism, and that's what we're trying to understand. So how to explain the changes in the upper airway on manipulation? When you start moving the mandible, how do you explain the changes in the upper airway, which are further distal to that? And of course, the upper airway really is the pharyngeal wall. And the wall of the pharynx is a musculo-membranous wall. It's got muscles, and it's also got other structures. So for example, if you put an endoscope and look down, you see the mucosa of the airway, and beneath that you have the submucosa. If you were to look at the airway from the top down, the first thing you would see is the pharyngobasilar fascia, which is my favorite fascia, by the way. So the upper airway is actually attached to the cranial base, very specifically at the pharyngeal tubercle. And from the pharyngeal tubercle, you have the pharyngeal raphe that comes all the way down. And then as it comes down, you have the constrictors, the circular muscles, and the longitudinal muscles of the pharynx forming the lateral pharyngeal or pharyngeal walls. And surrounding those muscles, you also have the buccopharyngeal fascia. So we have considered muscle movement. We haven't really considered the other components of the upper airway, and that's really what I'm talking about today. And so what is it that we need to know? Well, previous studies have shown that the altered stimulation of the airway mechanoreceptors can alleviate or intensify sleep apnea. So not only do we have this muscular structure, we have this fascial structure, but we also have mechanoreceptors. And depending on the signals that those receptors received, you can make sleep apnea actually better, or you can actually make it worse. Okay. And so here's another study here looking at the effects of anesthesia on upper airway resistance. But the point here is that deformation of the upper airway by negative intratransmural pressure alters the activity of the upper airway mechanoreceptors, causing a reflex increase in upper airway muscle activity. In other words, when this airway is breathing in, breathing out, going to collapse, that information is picked up by the mechanoreceptors in this pharyngeal wall, and during wakefulness, they can cause a reflex increase in the upper airway muscle activity. You defend your airway during wakefulness, okay? And so what we can see here is that the receptors are in the upper airway. They contribute to the maintenance of the upper airway whilst people are awake. Now, so the data suggests that this reflex response in upper airway mechanoreceptors can prevent pharyngeal narrowing during sleep. The problem, of course, is that these receptors may be defective in OSA, and so the reflex doesn't come into play, and this airway is more likely to collapse. So looking at another paper here, glossopharyngeal but not palatal muscle activity relates to pharyngeal pressure. This is going back to 2012. So again, the local stimuli controlling the pharyngeal dilator muscles are not well understood. So we have the dilator muscles, But how are they controlled? We don't really know, but local mechanoreceptors are a leading possibility. So this information is being detected, and there's a response to say, hey, what are we going to do with this information? So what we know is that the intrapharyngeal pressure inside the airway can actually modulate genioglossus activity during wakefulness, but there's a fall in muscle responsiveness during sleep. So it's very interesting to say that, okay, during wakefulness, we can do something about it, but when we go to sleep, we know there's this lack of responsiveness, increased likelihood of airway collapse. And that was shown for the genioglossus muscle, the tongue muscles. The activity was not shown in the tensor palatal muscle. And maybe that's a reason why there's emphasis being placed on the genioglossus modulation as opposed to the other muscles of the upper airway. But what is even more interesting is that the constrictors and the longitudinal muscles of the pharynx were not included in this study. And the reason for that is they're difficult to access. It's difficult to get information from an EMG from the muscles of the middle constrictor, superior constrictor, inferior constrictor, stylopharyngeus, salpingopharyngeus. They're difficult to access. And so what we know is there is a muscle response from genioglossus, but as I mentioned at the front, at the beginning, that may be compensatory for the fact that the actual airway musculature is not being responsive. So, okay, how can we start to work with this idea clinically? Well, there's several electrostimulation procedures, both non-surgical and surgical. So look at the surgical one. This is the transoral awake state neuromuscular electrostimulation for sleep apnea, mild sleep apnea. And basically, we have this transoral neurostimulator device. You place it on the tongue. You use it during the daytime. And in this study, they use this device on the tongue for about 6 weeks. And what they found is a significant fall in the apnea-hypopnea index from about 10 down to about 6 events per hour in the participants. And so for mild sleep apnea, this may be a way of being able to reactivate that genioglossus muscle. Another way is to use transcutaneous submental electrical stimulation. So instead of going to the tongue this time, we're now in the submental region underneath the chin. And when you do this, what you find is, again, this contraction of the genioglossus muscle. Again, we are saying, hey, let's work with this muscle. It's going to move in an anterior posterior direction. It's going to open up the airway. And now, what did it do when you do this TENS stimulation? What happens is you increase the tongue diameter, okay? And by doing that, the respiratory disturbance index falls. And so now we have, a method of working with the uniglossus and reducing ventilatory load. And that's a good point to say, how did you reduce the ventilatory load in these patients? And we have to think back to say, okay, the upper airway is attached to the cranial base using the pharyngobasilar fascia, and therefore there could be some elongation of the upper airway, caudal traction, and we know that caudal traction helps reduce ventilatory load. So that's an idea we're going to look at in a bit more detail as well. So here it is. You're going to use a TENS underneath the chin, and we can see with stimulation and without stimulation. And with stimulation, you see the distance from the skin to the tongue increases, and that's our proxy for upper airway, the caudal traction. And you can see here again the caudal traction, the elongation of the upper airway when you apply the TENS signaling. Now, this is applied to the skin of the neck, or if you use it inside the mouth and the tongue. And what we have on the skin and also on the tongue and the face, we have sensory innervation, which means you can feel the signal on the skin. So if you use this device whilst you're asleep, it will open your airway, but it might disturb sleep because you're actually able to feel the signal on the skin. But the point I was trying to make here was the caudal traction reduces ventilatory load, and that is one of our objectives. Now we move to the surgically implanted electrostimulated procedures, and you guys are very familiar with this. These are several techniques have been used to treat, prevent sleep apnea, and these include hypoglossal nerve stimulation, cervical stimulation, and other procedures as well. And you guys are very well aware, again, here is that cutaneous innervation of the neck. So these implants are below the skin, and so you don't get a sensory stimulation of the neck of the skin or on the face whilst you're asleep. That's just to show you a superimposition of the nerve supply. Now, if we go a little bit deeper and say, okay, what is our target with surgically implanted procedures here? Well, one of the targets can be the phrenic nerve. C345 keeps the diaphragm alive. And so if there is central sleep apnea, we can have phrenic nerve stimulation to prevent or treat central sleep apnea in those types of cases. More commonly, what we have is there's the phrenic nerve there. You can see the roots at C345 in gray. And another option here is the antecervicalis. We can see it's right about here, this kind of loop of tissue here, of nerve tissue. We can see that the inferior root comes from C2 and C3, and the superior root here is coming from C1. So this kind of U-shaped is going to supply the strap muscles of the neck. And so antecervical stimulation is another option for modulating the upper airway. And more commonly still, as you know, hypoglossal nerve stimulation. And that's going to, of course, modulate the hypoglossal nerve and then push the tongue forwards and open the airway in that fashion. So let's look at electrostimulation of the upper airway. And this is a relatively new approach, and it's going to augment the neural output to the upper airway dilator muscles, specifically genioglossus. And it's different because it's different from CPAP. So what PAP does, positive airway pressure, it's a pneumatic splint. It's a bit like a balloon. You're blowing air into the airway, and you're keeping the pressure there to prevent it from collapse. So there are three different approaches: neurostimulation using an implant. You can use PAP pressure to keep the airway open pneumatically. And the third idea was the mechanical enlargement using the oral devices. And so there are different modalities that we can use. And my question is there anything else that we haven't looked at so far? So you're very familiar with hypoglossal nerve stimulation. You can see that the sensing electrode is placed, and when the diaphragm stops moving, you have an impulse generator, which is implanted into the chest, for example. And then we have the electrode that's going to stimulate the hypoglossal nerve and push the tongue forward and open up the airway. So you're very familiar with this technology already. The issue with this is that it may not address lateral airway collapse because in this technique, the main target is the genioglossus, which is the anterior posterior opening. However, if patients have lateral airway collapse, this may not be the treatment of choice because you're not really addressing the underlying issue. And so for that reason, the surgeons came up with an alternative antecervical stimulation during sleep apnea. And what this study showed is ACS is an emergent neuromodulation technique. It potentially treats sleep apnea by generating this caudal traction effect. And so here's the antecervicalis that we already mentioned. And that's a target of stimulation in these cases. Now, when the stimulation is applied, what happens, you get the caudal traction, but also you get this medial-lateral opening. So the lateral walls are being addressed using antecervical stimulation. And so this is a very interesting phenomenon for us to understand, saying, okay, when I stretch the airway, it seems to open up. This is the idea with the phonetic bite. You stretch the airway, it seems to open up. So there seems to be some underlying mechanism here which can be addressed surgically and non-surgically, and maybe in some other ways as well. And so the anticervicalis, what it does, it stabilizes the lateral walls, increases the retropalatal cross-section area of the airway. And this study was done during drug-induced sleep endoscopy. But the point I'm making is it seems to mimic the physiological upper airway behavior. This is a biomimetic approach. We want to copy the body, mimic the body physiology, rather than replace it or try to kind of override it. So now I'm thinking, are there any other stimulatory options that we haven't really considered? Let's look at the nerve supply to the pharynx. And what we know is that the structure of the pharynx are supplied by the pharyngeal plexus. And we know the pharyngeal plexus, it lies in the connective tissue in the buccopharyngeal fascia, actually, which is superficial to the constrictive muscles, especially the middle constrictor. So now we have this pharyngeal nerve plexus. It's lying in the buccopharyngeal fascia, which is surrounding the muscles. And so this is a potential target of therapy. And just to review the pharyngeal plexus, what does it actually supply? It supplies most of the muscles of the pharynx. So these are the muscles that haven't really been addressed by electrostimulation so far. And also it supplies muscles of the soft palate. So it's a pretty nice target because these are the pharyngeal structures that we are very kind of interested in. And this diagram, you can see the pharyngobasilar fascia here right on top. Here's the cranial base. Here's the pharyngobasilar fascia. And then you can see the upper airway muscles are attached. And so when these guys are going to contract, there is the attachment here at the cranial base. So remember the pharyngeal wall? The pharyngeal wall here, it's got muscles, it's got the pharyngobasilar fascia there, it's got the submucosa, it's got the buccopharyngeal fascia, and inside of that we have the pharyngeal plexus. So let's look at the buccopharyngeal fascia. You can see in gray here, it looks like a kind of sheath, like a covering. The buccopharyngeal fascia is this dense connective tissue. It covers the pharyngeal constrictor muscles. It contains the pharyngeal plexus, and it continues downwards into the thorax, covers the esophagus and the trachea. This is the tracheal traction, the caudal traction that we have seen in other cases. And so the idea here, here's my kind of hypothesis, is the purse seine hypothesis. Purse seine. Purse seine is a fishing net. It's a large net used to catch fish by inserting them and then pulling the bottom of the net closed. In other words, when you pull this net from the top, the bottom closes. And if you turn that upside down, if you were to stretch that net, the top would open instead of closing. So my model here is the inverted purse seine model. That's the idea we're going to use. We're going to say that the buccopharyngeal fascia behaves like a purse seine. Now we have to take that idea and now we have to think about what is the nature of physiological signaling. We get the idea mechanically. How do you produce that effect physiologically? And that's the question. So we'll look here and say that a working hypothesis is that reflex pharyngeal dilated muscle response to large negative pressures are responsible for keeping the airway open. And so what happens is that when we are, when the mechanoreceptors pick up the fact there's a negative pressure, there's going to be a reflex reaction saying, hey, I want to keep this airway open. I'm going to resist that collapsing pressure. So the increase in apnea index, falling upper airway, anesthesia supports this hypothesis. So when you take that reflex away, the apnea gets worse. The body, there's no reflex reaction, it actually gets worse. And so this reaction is associated with vibration. Snoring itself produces a vibration, and that may be the stimulus for this reflex reaction of opening the upper airway and improving the upper airway stability. So now what happens in this case is the muscle that is activated is, surprise, surprise, genioglossus glottis. So again, this is compensation. This is not correcting the underlying etiology. What's happening is the body realizes, hey, I'm in danger of upper airway collapse. The reflex is to activate genioglossus, open the airway anterior posteriorly. But what we actually want is the medial lateral opening, which is more physiologic. So again, the tongue protrusion is a compensatory mechanism, in my opinion. Okay, genioglossus responds to mechanical vibrations of the mandible. So now I'm going to apply a vibrational stimulus to the mandible and see what the genioglossus does. So the extrinsic muscles are activated in coordination with the pharyngeal muscles to open the airway as needed. Okay, the genioglossus is modulated by several reflexes via the mechanoreceptors of the upper airway. So we now know that we have to target those mechanoreceptors, and by doing that, we will get this genioglossus response. So the results of this study represent that the genioglossus muscle can be evoked with mechanical vibration applied to the lower jaw. We can compensate in the same way that the body compensates by activating genioglossus, which again is a compensatory model. And this was done in healthy patients during wakefulness. So when we think about, hey, how can we apply vibration? Well, you can use CPAP, because in nasal CPAP, one of the possible mechanisms of correction is mechanoreceptor stimulation, which releases an increase in airway tone when the CPAP is actually applied. And so this upper airway tone may be targeting genioglossus. Now, the funny thing is that you can get both suppression and augmentation of genioglossus activity whilst on CPAP. And so again, it comes down to saying, hey, I've got to get this signal within a certain window, a certain specification. I don't want to make a bad situation worse. I have to be very careful in my targeting to make sure that when I do the stimulation, I get my genioglossus muscle to behave accordingly and not make things worse. So now my question is, are there any alternatives to electrostimulation? Well, one of the things we've been working on for the last, I don't know, 10, 15 years, 20 years, I'm getting old, is cyclic intermittent signaling. Cyclic intermittent signaling is how the body likes to accept signals in certain instances. For example, CPAP is intermittent positive airway pressure. It's very different from CPAP, which is continuous positive airway pressure. And so here's the idea, is that what CPAP does is very different from CPAP. CPAP, as you see the red line, is continuous airway pressure, keeps the airway open. But the CPAP, the pressure is only applied at the end of expiration when the pressure is low and increased likelihood of upper airway collapse. You don't apply it all the time. It's intermittent. And so that seems to produce a better response, better patient adherence to CPAP. It's more comfortable because it's actually addressing the underlying physiological issue of when does the airway collapse and not being there continuously all the time. Now, this idea of cyclic intermittent signaling, I use that same idea in the DNA appliance, which was, the FDA approved device that I talked about. And the feature of that device is these 3D axial springs. So these springs are made of super elastic nickel-free titanium wire. And so the wire is very kind of interesting because when you compress this wire very gently, when you bite together, when teeth come into contact, the spring is actually compressed. And so what the wire does, it stores the potential energy. And when the teeth are not in contact, that wire will vibrate and provide a cyclic intermittent signaling to the teeth, specifically the periodontium, the so-called periodontal ligament. And inside the periodontium, there are stem cells. And what they do is they differentiate into osteoblasts, lay down new bone, and then remodel the bone in this technique called, quote, partial expansion. It's a bit more to it than that, but you get the idea. This is cyclic intermittent signaling. It's not a continuous signal. Okay, so now we're going to use this idea in a very small pilot study. We've only done a handful of patients, but I just want to understand is there any value of pursuing this idea in clinical research and development? So we took a few volunteers. We had about 5 or 6 volunteers, probably about 7 by now. Okay, and what we did is to scan their airway. We had a sonographer to use a ultrasound device and get the eco-architectural information from the upper airway. And then they were also given a home sleep apnea test. So these devices, these volunteers used the device for about 15 minutes during the day and applied very specific biosignaling, okay? And they used that for about 15 minutes each day during wakefulness, during the day, for about 4 weeks approximately. And then after 4 weeks, we took another ultrasound image, and then we looked at the airway to see was there any changes in the longitudinal axis, in the axial plane, the cross-sectional area, and then we measured the upper airway length, the cross-sectional area, and the upper airway volume to say after 4 weeks using this, signaling, did anything happen? So here's some of the kind of preliminary results of this, ultrasound imaging. We did it in inspiration. We did it in expiration, the end tidal volume when the airway is most likely to collapse. And we were able to derive circumference measurements, area measurements, volume measurements of the upper airway at rest, at inspiration, at expiration. And we did that 30 days downstream after using the device. So this is the expiration data, very early stuff. But generally speaking, the distance from the skin to the tongue generally speaking, increased. This is very similar to the findings of the other 2 studies that I mentioned. And so this is the same phenomenon of caudal traction that we are interested in. Now, with caudal traction, as we saw with the ansa cervicalis stimulation, what happens is you get an increase in cross-sectional area. And again, after 30 days, we see the same trend where if you get this elongation, you start opening the airway, the cross-sectional area. And because of that, the volume of the airway also increased. So the point here is that there seems to be some kind of value in pursuing this from a research point of view. This is the upper airway behavior. The question really is, what is the effect on sleep? Again, I don't have much data at this point, just a couple of patients. But in the first few cases, the sleep quality index improved from about 16 to 25. In the second case, it remained unchanged. In the third case, it improved from 25 to about 34. Of course, these sleep studies will be looked at in more detail by our sleep physician. This is really just brand new data, just came out. But it's promising because it suggests that biosignaling appears to be beneficial to the upper airway. And these results are kind of similar to what's been reported with the surgically implanted nerve stimulation procedures, for example, antecervicalis stimulation. And so there may be some kind of value in pursuing this idea a little bit further. But I want to kind of, summarize and finish with what I think is going on. So this is my myofascial stretch hypothesis. I'm going to be using the inverted purse scene model to be able to describe that. And so what we have here is the constrictors of the pharynx. Now, historically, they're called constrictors of the pharynx. The reason why is because they have no active dilation capability. They are only constrictors. Now, if you think about the human eye, you've got sphincter papillae and dilator papillae. You've got 2 sets of muscle, one to constrict to make the pupil smaller, and one to actually actively dilate it. The upper airway does not behave like that. What we have is constrictors that can close the airway, but there's no muscular mechanism to open it. So now the idea is that when the airway is constricted, potential energy is stored within the myofascial sheath. This is the hysteresis that I talked about. And so now we have energy that's stored within the myofascial sheath. Now, what we know about the myofascial sheath is it's viscoelastic, stores that energy. So when the muscles actually relax, hysteresis occurs, and it produces the medial lateral opening based on the hysteresis curve. So this is in normal, healthy individuals. So what happens in OSA? In OSA, the potential energy stored in the myofascial sheath is unable to counteract the hypotonia the gravity, the tissue pressure, all of the age changes that occur as the muscle tone starts to get weaker. The myofascial sheath doesn't have sufficient energy to reopen the airway, and that it leads to collapse, which leads to sleep apnea. Now, because of that, we want to, have a good survivability. The genia glossus activity compensates for that, but it produces anterior posterior opening as opposed to medial lateral opening. Now, to get back to the actual physiological mechanism, using surgery, which we showed the multi-level surgery, the antecervicalis simulation, and the new biosignal that I just showed you, we believe that that targets the myofascial hypertonia, reestablishes upper airway medial lateral opening, and abolishes upper airway collapse. So it's an interesting idea, at least in my opinion, to say surgical techniques, implantation techniques, and non-surgical biosignaling, we may be able to recover the physiological mechanism for upper airway opening and keep the genia glossus as a secondary backup mechanism as a compensation if it's needed. So with that, I would like to really thank you for your attention today. I want to thank the ICC team for putting this webinar together. If you guys have any questions on the panel, I would love to hear your opinions too.
Thank you so much, Professor Dave, for this wonderful presentation.
Thank you very, very much, Professor Deb.